Imagine your body's repair system, right? Like the cells that are specifically designed to heal your cuts, maintain your tissues, just keep everything running smoothly.
Right, the maintenance crew.
Exactly.
Yeah.
But imagine they suddenly suffer from this, like, severe amnesia, and instead of repairing damage, they just start paving over your vital organs.
Oh, yeah.
Paving over your most delicate anatomy with this thick, suffocating concrete.
Which is a terrifying thought.
It really is. And, well, welcome to today's deep dive. We're so glad you are joining us because today is about what happens when that biological betrayal hits the absolute most sensitive area of a woman's body.
It's a very intense topic today.
Very. We are looking at a highly specific, honestly, incredibly complex question that we pulled right from the clinical data you shared with us.
Yeah, and it's a scenario that sits right at this fascinating intersection of, autoimmune disease, sexual health, and regenerative medicine.
Okay, let's unpack this. The mission today is to answer this exact question. Can a regenerative treatment, specifically the O shot, be performed in patients with active systemic sclerosis?
Also known as scleroderma, right?
Right, scleroderma. Can it be performed on these patients who are experiencing severe vulval fibrotic changes?
And to get there, to actually answer that, we have to look far beyond just the treatment itself.
We really do.
I mean, we have to understand the fundamental cellular environment of the patient, because if you just look at the mechanics of the shot without understanding the pathology of the patient receiving it, you're missing the whole picture.
So we need to trace the path of the disease, figure out the physical reality of the damage, and then, look at the sheer mechanical force needed to fix it.
Exactly. So we have to start with the pathology of systemic sclerosis itself.
Let's do it.
So systemic sclerosis, or SSC, is an autoimmune disease where the body essentially, it over-repairs itself to the point of destruction.
Over-repairs itself.
Right. It's characterized by progressive cutaneous and internal organ fibrosis, plus these really severe vascular alterations. And the primary culprits here are activated myofibroblasts.
Okay, wait. So in a healthy system, regular fibroblasts are just, they're just maintaining the structural framework of our tissues, right?
Yeah. They're the background maintenance crew. They quietly do their jobs. But in SSC, these cells become hyperactive. They become myofibroblasts.
They get activated.
Exactly. And they produce these massive, just exaggerated amounts of collagen and extracellular matrix.
Just dumping it everywhere.
Literally dumping structural proteins into the skin, the lungs, the kidneys. But, and this is where it gets really interesting in the pathology data you shared, there's this terrifying phenomenon that goes way beyond normal cells just working too hard.
This is the part that completely blew my mind.
Yeah, it's a process called cellular transdifferentiation.
Which sounds like sci-fi.
It really does. Because the activated myofibroblasts, they don't just come from existing fibroblasts dividing and multiplying. Right. The body actually recruits perfectly normal cells like endothelial cells that line your blood vessels, or epithelial cells, even adipocytes, which are fat cells.
Oh, well, healthy cells.
Normal cells. And the body forces them to change their phenotype. They completely transform into these fibrosis-causing myofibroblasts.
I mean, it's like the body's repair system just goes completely rogue. The plumbers and the electricians suddenly decide, hey, we are all bricklayers now.
Right.
And they just start building concrete walls everywhere, choking off the normal tissue.
That analogy captures the chaos perfectly. And, this rogue behavior doesn't just happen in a vacuum.
It needs a trigger.
Yeah. It is driven by a highly toxic environment within the tissues. Specifically, we're talking about severe oxidative stress and the overproduction of certain growth factors.
Like the TGF-beta.
Yes, transforming growth factor beta, TGF-beta. That toxic soup is what signals those plumbers and electricians just, abandon their normal jobs.
Okay, but if we look at the clinical presentation of systemic sclerosis, right, one of the earliest signs is often Raynaud's phenomenon.
Very common, yeah.
Where the fingers turn white and blue from lack of blood flow.
Right.
But why is the vascular system taking such a massive early hit if the disease is primarily about, overproducing collagen? Like, why the blood vessels first?
Well, if we connect this to the bigger picture, that points directly to a specific type of transdifferentiation called endothelial mesenchymal transition.
Endo-MT?
Exactly, endo-MT. The endothelial cells, those really smooth, delicate cells lining the inside of your capillaries, they aren't just being passively crushed by scar tissue from the outside.
Wait, they aren't?
No. Because of the oxidative stress and the hypoxia, the lack of oxygen, they're actively transdifferentiating.
The blood vessel walls are literally turning into the scar tissue themselves.
Yes, they lose their endothelial markers like CD31, and they acquire mesenchymal markers. They actually change shape.
That is wild.
They detach from the vessel wall and they start pumping out collagen. So this completely destroys the integrity of the blood vessel.
Because the pipe itself is becoming a brick.
Right, causing microvascular obliteration.
Yeah.
You lose the capillaries entirely. And think about what happens next. That generates more tissue hypoxia.
Because there's no blood flow.
Exactly. Which in turn generates more oxidative stress, which triggers more endo-MT.
Oh, man. It's just a completely vicious cycle
Yeah.
of vascular injury and scarring.
It is, and it sets the stage for the rest of our discussion, because if this rogue transdifferentiation is happening systemically, we have to look at what that biological disaster physically looks like when it hits highly specialized, very delicate tissue.
Which brings us to the vulva.
Yes.
Because the manifestation of this kind of fibrosis in the vulval region is, it's just profoundly debilitating.
It's devastating for the patients.
And the clinical literature you provided actually details vulval fibrosis really extensively through the lens of another condition, right? Lichen sclerosis or LS.
Right, because the fibrotic end stage of vulval SSC and LS, they share very similar mechanical and structural challenges. So using LS as a clinical parallel is really vital for understanding the severity of what these patients endure.
Because the endpoint looks very similar.
Exactly. LS is a chronic inflammatory condition, and the tissue remodeling it causes is incredibly aggressive.
Yeah, just reading through the sources on lichen sclerosis, the reality of this tissue change is heartbreaking. You have intense itching, burning, severe vaginal atrophy.
The tissue just thins out and becomes incredibly fragile.
Right, but it goes beyond just tissue thinning, doesn't it? Because those rogue prick layers essentially pave over the anatomy.
They do. It frequently leads to a condition called phimosis.
And this is where the clitoral hood completely scars over the clitoris, right?
Yes. It physically traps it under this thick, just unyielding layer of fibrotic tissue.
Like concrete.
Literally. It destroys sensation and makes any kind of intercourse or even just basic touch excruciatingly painful.
I can't even imagine.
And we also have to consider the cellular environment here. In these severely inflamed, scarred areas, there is a recognized 10% risk of developing squamous cell carcinoma.
Wait, really? A 10% cancer risk?
Yeah. The tissue is under such constant, severe inflammatory and oxidative stress that cellular mutation becomes a very real, measurable threat.
You really start to grasp the psychological and physical toll this takes on a person. There was a case study in your sources about a soldier or a woman serving in the military.
That case is really striking.
She had to march in full tactical gear while suffering from this condition. Just, imagine the sheer agony of marching with a heavy pack, the friction with bleeding, tearing, deeply scarred vulval tissue.
It's awful.
And having to just push through it because you're on a march.
It is a level of chronic pain and disruption to a patient's quality of life that fundamentally alters how they exist in the world.
Absolutely.
And historically, the medical response has just been inadequate for the severe stages.
What do they usually do for it?
Well, the standard frontline treatment for lichen sclerosis and often for autoimmune-driven vulval inflammation is the daily application of a highly potent topical steroid ointment.
Clobetasol, right?
Usually clobetasol, yes.
But you might be wondering, how does a topical steroid even stand a chance against that level of cellular mutation and scarring? The sources indicate that clobetasol manages the symptoms, but it's not reversing the actual architecture, is it?
No, it isn't. Steroids like clobetasol are immunosuppressants.
They just turn down the volume on the immune system.
Exactly. They reduce the inflammation. And for many patients, that successfully relieves the acute itching and burning, which is great.
Sure, symptom relief is important.
But suppressing the immune response does not reverse structural damage that has already occurred.
Yeah.
If the myofibroblasts have already built a dense fibrotic wall over the clitoris, putting out the inflammatory fire around it doesn't dissolve the wall.
Right. The fire is out, but the concrete is still there. So to restore function and elasticity, you need a therapy that fundamentally dismantles that bad architecture and forces the tissue to rebuild.
Which brings us to the O shot.
Okay, here we go.
Yeah.
If high-powered steroids can't reverse a severe vulval scarring, How does a regenerative procedure actually break down this level of fibrosis?
Well, the O-shot utilizes platelet-rich plasma, or PRP.
Okay.
Traditionally, the procedure begins with a blood draw from the patient. That blood is placed in a centrifuge and spun down.
To separate everything out.
Right, to isolate and concentrate the platelets and the plasma, removing the red and white blood cells.
Because platelets aren't just there to, like, form scabs when you get a paper cut.
No, not at all.
They are packed with growth factors.
They contain these things called alpha granules, which act like biological cargo ships. When they're activated, they release a massive payload of growth factors.
Like what kind?
Things like vascular endothelial growth factor, VEGF, and platelet-derived growth factor, PDGF.
Okay, the actual building blocks.
Yeah, the signaling molecules. When this concentrated PRP is injected back into the vulva and the clitoris, it delivers these biological signals to trigger tissue regeneration and angiogenesis.
Which is the formation of new, healthy blood vessels.
Exactly.
But if we're dealing with concrete like scar tissue, just dripping some growth factors on it doesn't seem like enough, right? And your sources highlight a really fascinating medical debate about how the O-shot actually works for these severe conditions.
It is a great debate.
Because you have Dr. Goldstein, who's this prominent figure in sexual medicine, suggesting the benefits of PRP are purely biochemical.
Right, the biochemical cascade theory.
Like the growth factors just do all the heavy lifting.
It assumes the signaling molecules alone are what alter the tissue state.
But then Dr. Charles Runels, who actually created the O-shot procedure, he pushes back on that.
It does.
He argues that when you are dealing with dense scar tissue like phimosis, it has to be a mechanical procedure combined with a biochemical cascade.
Yes. Dr. Runels emphasizes a concept called hydrodissection, which is incredibly vital for treating advanced fibrosis.
Here's where it gets really interesting. I love this concept.
It's brilliant.
The needle and the fluid aren't just a passive delivery system, right? They are literally acting as a liquid scalpel to blast apart the scar tissue from the inside.
That is the exact mechanism. When a skilled practitioner injects the PRP into that densely scarred phimose tissue, the physical volume and pressure of the fluid forcefully separate the adhered tissue layers.
It just forces them apart.
Yeah, along the fascial planes. It mechanically breaks apart the fibrotic adhesions that are physically trapping the clitoral anatomy.
It's like controlled demolition inside the tissue.
It is, and it is often combined with targeted microneedling of the most sclerotic areas.
Oh, to poke holes in it.
The needles physically break down the dense collagen bundles. So you have this immediate mechanical freeing of the trapped anatomy.
Right.
And that is simultaneously followed by a massive biological flooding of the area with those concentrated growth factors.
It makes so much sense. You tear down the bad concrete with hydrodissection, and then you immediately hand the tissue, the blueprints, and the materials to build healthy, elastic blood vessels.
Exactly. It fundamentally alters the tissue architecture in a way that no topical immunosuppressant ever could.
Okay, so we understand the systemic pathology of systemic sclerosis. We get the agonizing reality of vulval fibrosis. And now we see the mechanical and biological demolition power of the O-shot.
We have all the puzzle pieces.
Which brings us to the core mission of this deep dive, the ultimate question you brought to us.
Right.
Can we safely perform this highly effective O-shot on a patient whose vulvofibrotic changes are being caused by active systemic sclerosis?
Well, if you look strictly at efficacy, the clinical literature says yes.
Okay.
The sources provide clear evidence that PRP is effective for SSC-related fibrotic complications. I mean, it's been successfully used to treat severe refractory SSC skin ulcers on the fingers, and even for facial microstomia.
The severe fibrotic shrinking of the mouth opening, right?
Yes. So it works.
But, and this is a big but, if you're looking at this from a regenerative medicine perspective, your immediate instinct is to just use the standard O-shot protocol.
Which uses autologous PRP.
Meaning you spin down the patient's own blood.
Right.
But based on everything we just discussed about how scleroderma works, aren't the patient's own platelets part of the weapon the disease is using?
And there it is. You've identified the critical caveat that practitioners absolutely must navigate.
Because it's systemic.
If we connect this to the bigger picture, systemic sclerosis is heavily characterized by systemic platelet hyperactivation.
Okay, how does that actually happen, though? Why are the platelets hyperactive in these patients?
Well, think back to the endo-MT we discussed, the destruction of the blood vessels.
Right, the pipes turning into bricks.
Platelets are biologically designed to activate when they encounter damaged blood vessels, right, to stop bleeding.
Yeah, that's their whole job.
In a systemic sclerosis patient, the endothelial lining of their vascular system is constantly damaged and inflamed. The platelets are constantly exposed to this widespread vascular injury and severe oxidative stress.
So they're constantly in a state of alarm. They think they need to be healing constantly.
Yes, they are chronically degranulating. They are continuously releasing profibrotic and pro-inflammatory mediators into the bloodstream.
So they're actually making the scarring worse.
This chronic platelet dysfunction actively contributes to the systemic vasculopathy and the fibrotic cascade.
Oh man, so what does this all mean? If a practitioner takes that patient's blood, spins it in a centrifuge to concentrate those exact platelets, and then injects them to a highly inflamed, severely scarred vulva,
You see the problem.
you're not delivering a healing payload. You're delivering a concentrated dose of the disease.
Exactly. Using autologous PRP in an active SSC patient is clinically counterproductive.
It's actually dangerous.
It demonstrates intrinsic limitations because the source material, the patient's own blood, is fundamentally altered by the pathology of the disease. The regenerative potential is compromised right from the start.
It's like handing a rogue construction crew a massive shipment of energy drinks and more bricks.
Exactly. You'd just be feeding the fibrotic cycle locally.
But we know the mechanical hydrodissection and the growth factors from the O-shot work beautifully for the scarring.
They do?
So how do we get the regenerative benefit without pouring gasoline on the autoimmune fire?
What's fascinating here is that the solution presented in the regenerative medicine literature is very straightforward. It's homologous PRP.
Donor PRP.
Yes, donor PRP.
So you just bypass the patient's blood entirely.
Exactly. By utilizing PRP derived from healthy, rigorously screened donors, the practitioner completely sidesteps the risk of re-injecting the patient's own hyperactive, disease-driving platelets.
But how does donor PRP compare to what a doctor would, just spin up in their own clinic? Is it just the same thing but from a different person?
Oh, it is vastly superior in its consistency.
Okay.
Think about it. When a clinic uses a standard tabletop centrifuge, they're just spinning whatever is currently in the patient's blood on that given day.
Right.
The concentration of growth factors can vary wildly depending on the patient's age, their diet, stress levels, and obviously any underlying disease.
You get what you get. It's kind of a gamble.
It is. But homologous PRP products are manufactured in highly controlled laboratory settings.
Oh, so it's standardized.
Very much so. These labs don't just spin the blood, they process it to achieve a high degree of standardization. They can filter out the white blood cells that might cause unnecessary inflammation.
Which you definitely don't want in an autoimmune patient.
Right, and they can ensure that the levels of crucial growth factors like the VEGF and PDGF we talked about meet specific high concentration thresholds.
So you are guaranteeing a potent, pure dose of the blueprints and materials.
Sure.
Without any of the rogue signaling.
Exactly. It completely isolates the mechanical and biological benefits of the procedure from the systemic risks of the patient's disease.
Okay, so bringing it all back to answer the core mission in your sources. The O-shot can be performed, and it can be profoundly effective for treating this severe, painful vulval fibrosis caused by systemic sclerosis.
Yes, absolutely.
Because the mechanical hydrodissection physically frees the tissue, and the healthy growth factors promote angiogenesis and healing.
Right.
But, and this is the massive takeaway, the practitioner must adapt the protocol. They cannot use the patient's own blood. They must use highly standardized, donor homologous PRP.
It perfectly illustrates why treating complex patients requires looking beyond the mechanics of a single procedure. You have to deeply understand the underlying cellular environment.
What an incredible journey through the body's hidden architecture today.
It's been a deep one.
We started by looking at how systemic sclerosis forces perfectly normal cells to transdifferentiate into rogue myofibroblasts, basically building concrete walls inside the blood vessels.
Yeah.
Then we saw how devastating that concrete is when it manifests as vulval fibrosis, causing unimaginable pain and completely altering a patient's life.
Yep.
And finally, we explored how the hydrodissection of the O-shot acts as a liquid scalpel to blast that scar tissue apart. With the absolute vital caveat that for scleroderma patients, the regenerative juice has to come from a healthy donor to avoid feeding the pathology.
It is a remarkable interception of mechanical intervention, molecular biology, and pathology.
It really is.
And, it leaves us with a rather profound concept to ponder as we conclude.
Oh, what's that?
Well, we spent a significant amount of time today discussing how normal cells, like endothelial cells and adipocytes are reprogrammed to transdifferentiate into fibrosis-causing myofibroblasts.
Right, because of environmental stressors like oxidative stress.
A biological
Yeah,
betrayal.
exactly. But this raises an incredible question about the future. If the human body possesses the cellular machinery to program an endothelial cell to turn into a scar tissue factory,
Yeah. Might the ultimate future of regenerative medicine lie not just in breaking down those scars mechanically with PRP, but in discovering the exact genetic or biochemical switch to make those cells transdifferentiate back into healthy, normal tissue?
oh, wow. So instead of just cleaning up the concrete, you actually convince the rogue bricklayers to remember they were supposed to be plumbers and electricians in the first place.
Exactly. Right now, we are currently treating the aftermath of the biological storm. The next frontier is learning how to rewrite the cell's instructions entirely.
That is incredible. It turns out the answer isn't just about finding the right treatment, it's about learning to speak the language the cells are already using.
Absolutely.
Well, thank you for taking this deep dive with us today. We will see you next time.